So today we're going to talk about assessing and measuring the patient effort during mechanical ventilation. And before I go into the details, it's a pretty big presentation, but we have 15 minutes, so I'm going to stay on time, try to stay on time. But this is an example of like you just intubated the patient. This is a pressure controlled ventilation. The patient is paralyzed, heavily sedated, and you decided I'm getting 13 driving pressure over 5 of PEEP. That's the tidal volume that I want, 380. A little bit later, the patient started, recovering from the paralytics, and you discover that on the same settings, you can see here that the tidal volume is getting higher. And you can notice, I want you to notice on the pink curve, which is second one, which is the flow curve, and you can see it a little bit distorted, not as the same one. So you said in your mind, no, 470 is too much. I'm gonna start. I want less tidal volume, so I'm gonna drop the inspiratory pressure to the patient. And then you notice you drop the inspiratory pressure to 10, and the tidal volume is still high. And then you say, well, I'm not happy with that either, so I'm gonna drop it even more down to 7 on the curve on the picture on the right. And you would notice what happened. The tidal volume is even like went even higher. And you again look at the pressure time curve on the yellow one on the top. You can see that scoop concavity there. And look at the flow again. You can see how convex it is. So my point from those slides is sometimes we underappreciate that the patient is working. And what we caused here by trying to reduce the inspiratory pressure from the ventilator, that we shifted the work from the ventilator more to the patient. So that's something, that's why it's important, to know how much the patient inspiratory pressure is working. So again, why is it important to measure it? And you will hear this many times. If the patient effort is too high, of course, we all know the term PSILI, patient self-induced lung injury, ventilator-induced diaphragmatic dysfunction, the dysynchronous, which is our main topic today. Of course, patients who are struggling and working too hard will have increased oxygen consumption. Of course, discomfort and sleep and agitation and delirium. So we don't want the patient to be working too high. Same token, we don't want the patient to be not working at all or working a little bit. Why? Mostly for diaphragmatic atrophy and weaning failure. So that balance, you have to have a good balance between, you don't want the patient to be working too hard, and you don't want the patient to be not working at all, because we know that some spontaneous effort during mechanical ventilation might be beneficial. I'm going to skip this. And again, this is just a curve. I'm putting it like a picture here. And you can see like you can under assist the patient and you cause problems on the pink on the left, and on the yellow, you're over assisting the patient and causing problems. So we are trying to always work on that green line, which is like adequate assistance. The question becomes, what is adequate assistance, and when do you want the patient to be resting? When do you want the patient to be working more? And those are really tough questions at the bedside sometimes. I'm going to jump into the equation of motion, which basically explains everything about mechanical ventilation. But again, sometimes we tend to forget that who's doing the work. It's usually the ventilator and the patient, the PMOS. And we all know for the pressure to be delivered, you have to overcome the elastic pressure of the whole respiratory system and the resistive pressure and the O2 PEEP if there is. And again, so it's always the patient and the ventilator should work in tandem to overcome this elastic and resistive loads for the patient. So you also heard a lot about the term work shifting. And if you look at the literature, the work shifting is really not defined very well or very loose. Because all what we know is work shifting is the patient is working, but how much the patient is working, that's very important. And how to quantify it, and what is adequate, or what is too much, or what is too little. So I don't know exactly those answers for you. but there's something called work shifting index. And the work shifting index, you want to calculate the patient's inspiratory muscle effort, which we call it the PMUS, divided by the P vent, or the inspiratory pressure for the vent. For example, if the patient is working by creating 10 centimeter water pressure, and the patient on a driving pressure of 10 centimeter, so that gives you almost 1-to-1, 50% of the patient, 50% of the ventilator. That might be too much if you just intubated the patient or the patient in the acute phase. Same token, this ratio might be too little if you're trying to wean the patient, trying to extubate him or liberate him for mechanical ventilation. So there is not a single good number. It depends on the patient condition. Now, how are we going to assess the inspiratory work? We can do it subjectively, clinically. We're all at the bedside and we can see if the patient is struggling, tachypneic, tachycardic, sweating, using accessory muscles. We can probably agree that the patient is working too hard. Although sometimes this even could be debated. Some of us would say he's working too hard. Some saying, no, it's not working too hard. So we want more objective criteria, more numbers. We all love numbers. So there are some surrogates of the patient inspiratory effort, and there's a real measurement of the patient effort. So the surrogates, which we use a lot at the bedside, the work of breathing, I'm going to go through each one very briefly. The PTP, or the pressure time product, the diaphragmatic electrical activity, if you have it, the EADI. P0.1 has been gaining a lot of popularity. P occlusion, the total airway occlusion. PMI, the patient muscle index. There's something called flow index. And if you like ultrasound, you can use diaphragmatic excursion or diaphragmatic thickness. We all know about the maximum inspiratory pressure and maximum expiratory pressures. But all of those, the ones that I put arrows, white arrows there, they're practically an estimate of the P muscle. They are not going to give you the exact how much inspiratory pressure the patient is generating. But if you want to measure the muscle pressure, you have to go with the esophageal balloon, which is the gold standard that we have right now. Now, this slide has some normal values. Again, these are normal probably for patients not in mechanical ventilation. When we breathe normal, maybe our PMUS is 5 to 10. If you work harder, it's more. Work of breathings, 0.3 to 0.6 joules per liter. The EADI, 5 to 20 microvolt. PTP, 50 to 100 centimeter water per minute. P0.1, nobody really knows, but -1 to -5 centimeter water. Occlusion pressure, don't have like a normal value for it. PMI doesn't. Diaphragmatic excursion may be more than 11 millimeter. So let's go through each one quickly. Again, this is a subjective clinical, and we all know that intercostal muscles, the intercostal retraction, abdominal paradox, and so forth. So esophageal balloon, sorry, the picture here, the curve may be a little bit blurry. If you use esophageal balloon, it's actually, I'm going to tell you, since we're going to talking about patient-ventilator interactions, if you really want to diagnose or see clearly the patient-ventilator interaction, you need an esophageal balloon. Or EADI if you have it. So the esophageal balloon goes into like the lower third of the esophagus, and you can see it here at the third row. The orange one, when the patient breathes in, he creates negative pressure. If the patient is passive, not breathing at all, you would have a positive deflection. And if you have the esophageal balloon inserted, here's the equations. There will be a lot of equations. I'm not going to try to talk about exactly all the calculation and the math behind it. But if you have the esophageal balloon, you can calculate the PMUS, which is the difference between the passive pleural pressure, meaning when the patient is totally relaxed, minus the pleural pressure when the patient take a breath. And if you want it to be more complicated, it's the elastance of the chest wall multiplied by the volume, plus the resistance of the chest wall multiplied by the flow, plus the pleural pressure exhalation minus the pleural pressure inspiration, which is, if you can look at this, it's basically the equation of motion. So to simplify it, if you have the esophageal balloon, the PMOS will be the elastance of the chest wall times tidal volume minus the delta change of the esophageal pressure during breathing. I know it's kind of like clinicians are not mathematicians, so we're not very good at math. If you have it, you can just simplify it, although it's not 100% accurate. Look at the delta esophageal pressure. So if I go back to that first picture here, during relaxation, say this was 10, the inspiratory pleural pressure, and when the patient took a deep breath, it went down to -10. So that's a delta of about 20 centimeter water. And I have this example again, and inspiratory esophageal pressure 13, and the expiratory is -8. So 13 minus -8 equal 21. All right, let's go to the diaphragmatic electrical activity of the diaphragm. And this is only in one ventilator, the Servo Mackay. And it's basically measured the electricity coming through the phrenic nerve to the diaphragm, and it's called the EDI peak. Again, it needs a specific catheter, again, into the esophagus, and it's only in one ventilator available. So if you don't have that ventilator, you can't use it. The good thing about it, you can use it whether the patient is in positive pressure or negative pressure. It only estimates the respiratory drive. So because it measures electricity practically, it does not give you the exact PMOS. But there is something called neuromechanical efficiency index. One study talked about creating a formula for neuromechanical efficiency index, which you can see it here. And it showed to correlate with the PMOS of the patient. Okay, moving on. We talk a lot about work of breathing, or the WOB. Sometimes the ventilators, if you look at the ventilator and it gives you work of breathing, or sometimes the patient will be working too hard. And a lot of times the residents would tell me like, oh, the patient has work of breathing is elevated. And it's like, how did you calculate it? Because probably to calculate true work of breathing, again, you need an esophageal balloon catheter. And it's basically, again, a lot of math, the integral of the chest wall elastance minus esophageal pressure multiplied by the delta volume, or the change in the tidal volume. And if you can see it in this graph, this is the PV curve, pressure volume curve, using the esophageal pleural pressure versus the tidal volume. And it's that area in red here. Again, this is more the diagram, and you can calculate, divide the work of breathing into for the elastance or the chest wall elastance. So again, if you need to calculate it, you probably need an esophageal balloon, although sometimes the ventilators will give you some kind of crude estimation of the work of breathing. Pressure time product is another way, again, that gives you an objective way of estimating the patient effort, not the whole true effort. And again, the integral of it's basically that green area here. So it's a change of esophageal pressure multiplied by the time over 2. Airway occlusion pressure at 100 millisecond, P0.1. This is again been gaining some momentum over the last maybe 10 years or more. And we did some work here, and the beauty of this P0.1, it's available in most ventilators, and it's non-invasive. Different ventilators calculate it or measure it in a different way. So we did this study, like we showed that it correlates, it's a bench study, it correlates almost perfect with the PMOS. And doing some statistical analysis, we found that if you want to estimate the PMOS equals 3.95, the P 0.1 minus 2.05. So it's, again, very easy to quickly estimate. If you want to do it more, there's something called occlusion pressure. Instead of only 100 milliseconds, you can do it for one full breath. And the patient basically is trying to breathe against an occluded valve so he doesn't get the breath. And again, we did the same in the same study. We tried to correlate it also with the PMOS, and we found a perfect correlation or semi-perfect. And we got this equation. If you want to know, estimate the PMOS, it's 1.1, the P occlusion plus 0.82. PMI, or patient muscle index. If the patient is in spontaneous breathing or in pressure support, you can actually do an inspiratory pause. And if you can see this curve, when you do the inspiratory pause, if the patient has an effort, the pressure, the airway pressure will go up. So we call that peak. And if you subtract that peak from the plateau, that is the area, it's the PMI. So if the patient is in 5 and 5 pressure support and you're estimating you should get a plateau of 10, and you did that curve and you get 15, so the difference is 15 minus 10 is 5. Again, in the same study that I'm talking about, we found very good correlation, except in patients with obstructive cases like COPD, people who have high resistance or high compliance. And we also were able to get this formula 1.03 times the PMI plus 8.26. Again, I would caution to don't do it in the obstructive cases. Flow index, it's basically a measure of the flow. Remember, in the first one, I told you the more the patient work or breathing high, the flow curve will be convex. And if it's a straight line like this, it's about flow index of 1. So it's a visual, it's very hard to calculate really, but it's a visual inspection. If it's very convex, it means that the patient is working too much. And there was one study that showed that the values between 2.1 or 2.6, maybe will estimate the PMOS at about 5 centimeter, but it's above 4.5, it means that the patient is working too hard, more than 10 centimeter. To help you a little bit with those calculations, we have on the Society of Mechanical Ventilation page called calculators, and you would find some of these calculations. If you enter the PV 0.1, or it might help you. A lot of other options, kind of new and less used. I never used this, but it's called nasal pressure swing, which basically you put a probe in the occluded nose, and it estimates the change of the esophageal pressure. So if you can see, this is a graph that more the patient take a deep breath, the pressure goes down. Again, I don't want to run out of time. You can estimate it if you have a CVP, because usually CVPs are in zone lung 1, and it reflects the pleural pressure. We've been using the maximum inspiratory pressure, maximum expiratory pressure for decades, and the normal is 80 to 10. And we say if it's below 30, sometimes mean patient is weak and stuff like that. But the patient, of course, has to be cooperative and able to do this. Ultrasound been gaining popularity, and this is something called diaphragmatic excursion. So if the patient is breathing normal, quiet breathing, usually the excursion with the M mode here, you can calculate it, 1 to 2 centimeter. But if you take a deep breath, of course, the diaphragm should move higher. So usually above 5 to 10, maybe an estimate that the patient is working too much. Diaphragmatic thickness fraction, that's again been studied, not very accurate, but basically calculated as the inspiratory minus expiratory diaphragmatic thickness over the expiratory thickness. I put some references here. I know I tried to rush on in it, and there's a lot of topics, but I'm sure this will be discussed a little bit later, and if not today, maybe in further webinars. Well, thank you so much. I hope that was beneficial.